very happy to show you. I hope that you can visualize my slides. If not, tell it to me. Okay, perfect. So very quickly and simply, some slides about, as you said, about the architecture, the flows, and the room specificities in the ICU, and with some specificities related to SARS-CoV-2. So just to tell you that in France, we have a decree from the French Republic just explaining and describing all the characteristics and the properties that we need to have for our ICU regarding the organization, regarding the size of the room, regarding the treatment of air, regarding the pressurization of the room, positive or negative pressure, and so on. And so one thing very important in the organization of the ICU is the filter zone. And you can see here the picture of the filter zone in my unit. This is just a zone in between the administrative part, which is in front of the picture, and the care part, where you have patients and so on, behind the picture on my screen, where there is a guy working in the area. And so this part is just a zone which may split between these two very different parts, and just to manage the flow of relatives visit, the flow of patients, and so on. If you look at the room, the typical ICU room, you can see that in the decree, the size has to be 22 square meters. You have some requirements regarding the air change, at least 6 volumes per hour, plus minus air conditioning. And you can see, if you look at the room, you have a bed, especially it's better to have a bed to wait the patient, so directly. You have the respirator, the ventilator, on one part of the patient. You have the monitor, just to record the main characteristics, the heart rate, the blood pressure, the oxygen saturation. And you have some devices allowing continuous infusion for sedative drugs, for catecholamine, and so on. And you cannot visualize here, but just behind these continuous infusion devices, you have also a computer just allowing you in the room to have access to the electronic files, the biology of the patient, and so on. You have also, of course, other materials in the ICU that you need to have. This one to perform a dialysis, intermittent dialysis, and this one for VA ECMO in case of refractory shock, or sometimes you may use this device also for VV ECMO in case of very severe and refractory ARDS. In the area of care, you have also a monitoring centralization in which you have the nurses and the doctors just looking at the computers and the monitors, and just to do everything you have to do to care the patient. So this is the core of the ICU. What about the specificities of the COVID-19? Of course, all the healthcare workers had to be very well protected, as you can see, with a mask, with gloves, with a white coat or overall, so to be very well protected from the virus. And you need also to be, let's say, some numerous people, so it's a team action, for instance, here to perform prone positioning in this very severe patient. And maybe you know or you don't know that this patient had prone positioning in more than 50% of cases. So you need to have some team organization just to perform the prone position and to perform the resupination after a few hours in proning. And you can see you need a significant number of nurses, health nurses and doctors. Of course, for the intubation, you have some procedure, but maybe it will be discussed later. So just to illustrate the fact, also here it's not a patient, this is a mannequin, and you can train yourself on the mannequin just to perform the adequate intubation with this high risk of viral contamination. So what about the healthcare workers and especially the nurses? Also, the decree tells us that we need to have one nurse for 2.5 patients with one nurse helper for 4 patients. But for COVID-19, it's not a decree. This is a recommendation coming from my group, the APHP, that we decided that because the patients are very difficult to manage, very severe, we need to have one nurse for 2 patients. And this is probably key and critical because it allows you to better protect the healthcare workers because they are more numerous at the bedside. What about the protection of also of the healthcare? It regards the pressurization of the ICU room. So if you can, it's better to have a slightly negative pressure into the ICU room to protect the outside from the virus. And it was also suggested, but there is no data really to recommend that, to use some mobile air decontamination unit inside the room to clean the air, to remove the air, and to have a better air without the virus. But once again, it's not mandatory, and we need more data to recommend that. So in some rooms in the ICU also you may have, as you can see here, an airlock. So this is a space between the room behind here and the outside the room just in front of the picture. And this airlock may be in positive pressure while the room is in negative pressure. And so you have a very good protection of outside of the room protection of the virus. What about if you apply all this decree and recommendation? What about very quickly the percentage, the rate of contamination of healthcare workers during the first wave of the pandemic? In the APHP group, we did a survey just in April 4th, and we recorded the fact that around 4% of healthcare workers in the ICU were at a positive PCR. So it's a low rate, probably not so different from the global population, and probably that maybe most of them were contaminated outside the ICU, but we cannot have any demonstration of that. Just to tell you in introduction maybe of the next talks, what we had to manage and to face. And you have here in the Great Paris the number of ICU admission at the peak, and the peak was around April 8. You can see at least 3,000 patients in the ICU in the Great Paris. And if you can visualize in my group, the APHP group, we have to manage at least 1,200 patients in the ICU, while our usual number is a little bit less than 500. So we had, because we had also some non-COVID-19 patients, we have to multiply by around 3 the number of ICU beds. And so for illustration, in my hospital, before the COVID-19, you have the number of ICU beds and intermediate beds. And look at what we had to do during the pandemic and the first wave of the pandemic. We increased a lot the number of ICU beds and intermediate beds for a total number of beds much higher. And as a consequence, and it was a big deal, and this is why we do this training program, you can see that we had to increase a lot the number of nurses in our team from 43 to 90 nurses, as well as the number of intensivist fellows and of course materials. We increase a lot the number of ventilators and monitors. So I thank you for your attention.
Thank you very much. That was very helpful indeed. Now we can understand that there is a potential difference between the optimal situation and the minimal setting as you indicated, for pressurization and particular buffer room. It's not necessarily available everywhere, so we have to do with what we have. You said that the room should have 22 square meters, but if hypothetically in my hospital the rooms have only 21 square meters, I suppose I can still use that ICU, right?
Yes, probably you can, of course. This is just the ideal situation, and as you know, the French law is very rigorous, but as you know, in the past in France, many of the ICU did not apply this kind of standard, while we very well manage our critically ill patients. So this is a goal to achieve. This is not, let's say, completely mandatory, even though this is something in the law.
Yeah, and I suspect indeed it depends on the country and it depends on the hospital. In some countries, in very small towns, the ICU may not have the same structure and facilities, but indeed we should aim at what you presented. A question which is somewhat related to that is the question of ECMO that you mentioned. You mentioned the use of extracorporeal membrane oxygenators, ECMO, for those patients who have severe respiratory failure, and even veno-arterial ECMO for those having also perhaps cardiac problems. But this is not available everywhere. So I suspect that we sometimes have to transfer patients to other institutions like yours or ours for management with ECMO, correct?
Yes, correct. But I think in general, this is a little bit tricky to transfer this kind of severe patients for an assistance in another unit. And this is especially very difficult in this pandemic because patients were very unstable. And as we did a lot of transfer in France, because we transfer, for instance, many patients from the Great Paris into other areas of the country where the pandemic was less important, but it was a big challenge to do.
Well, yeah, but then the question comes, if I work in a small hospital where ECMO is not available, and I have a patient who is getting really worse and worse, I can no longer maintain oxygenation with mechanical ventilation. I tried prone positioning, as you showed on one of your slides, but it's still, the patient may still die from refractory hypoxemia leading to hypoxia. What should I do?
Yeah, but you know that I think this is the case in France, but probably in many European countries, you have mobile unit. It means that you call the unit is coming, you put and you insert the assistance in your small unit, and once the patient is under VV ECMO or VA ECMO, the patient is transferred in the big, let's say, the big unit. I think this is critical, indeed.
Indeed, that's what we wanted to discuss. Well, this was really excellent. Many thanks, Antoine. I think we will move to the next presentation.